This meeting.
Mind your way, Carmen? Okay.
Okay, like Lori said, I'm the Marketing and Communications Director at Cozad Community Health System. Thank you all for being here. We're here to teach you about Medicare and Medicare Advantage. Here to talk to you is Ivan Mitchell with Great Plains Health from North Platte. Miranda Pickenpaw, she is the, this is a mouthful, let me find it here. Clinical Care Utilization Review Coordinator. And Drenal Hardy is the Social Services Coordinator. Robert Dyer is the CEO. First, Ivan is going to talk to you about Great Plains Health and Medicare Advantage specific to them. And then Miranda and Drenal will talk to you more about the basics of Medicare versus Medicare Advantage. At the end, if you still have questions, we'll take your questions. And we have 2 more sessions after this, on the 8th at noon and on the 9th at 6 p.m.
At the Grand Generation Center.
At the Grand Generation Center and at
Paulson's. Yep.
Thank you. Good afternoon, everyone. Good to be here. I was talking to some board members and a few of you that work here. I've been in North Platte now for about 9 years. Prior to that, though, I ran a hospital about this size, hospital and nursing home in North Dakota, and so kind of get the challenges of critical access. But and this is actually a really important. This is some important information, and the way that it actually affects your local community hospital is kind of a big deal. So we'll talk a little bit about. Most of what we're going to share with you is just national information that's out there for anyone to pull up and see, doing a quick Google search. And then we're going to share with you a couple of things that are happening at Great Plains Health. Mostly it's going to be just sharing with you Medicare Advantage and some of the challenges that are out there. If you want to hit the next slide, we'll walk through kind of the national trends. And so Great Plains Health, we made the decision to go away from Medicare Advantage. We kind of want to walk you through that. And hopefully by the end of this, you'll understand why. Bring all the hard questions. We've done this a few times. I think I've heard just about every question. So if you have one, bring it up. And then we'll talk a little bit about how that impacts our physicians and our care providers. The next slide. So just a bit of a history. Medicare Advantage, created back in 1997 during the Balanced Budget Act. And at that time, Medicare Part C is Medicare Advantage. At that time, it was called the Medicare Plus Choice Program. And then in 2003, when they covered prescription drugs under Medicare, they changed the name to Medicare Advantage at that time. And then in 2007, it was about 19% of the population. Now it's about half of the Medicare population that have Medicare Advantage. And we'll kind of walk through why that transition has happened and kind of explain to you some of the implications to that. In Nebraska, it's quite a bit lower, and typically in your rural communities, it's even lower than that. But that's kind of where the Medicare Advantage beneficiaries are now at this point. I'm going to hit the next slide. So real quick, so the way that Medicare Advantage works. So what Medicare does is they, if they sign you up for Medicare Advantage, they'll say, okay, here's a Medicare Advantage beneficiary, here's how much we pay. Here's our average spend for Medicare beneficiary. They give that to the insurance company. And then the physician, they go about, you show up at the physician office, you show up at the hospital, they provide care to you, they order exams, order tests, order the appropriate criteria. And then the insurance company, they administer the Medicare Advantage, and they can choose whether to approve or not approve your care. And then so you can kind of see the way this process works. A lump sum is given to an insurance industry for them to maximize, for them to make money. That basically they're incentivized to kind of deny care and delay care. And so that's how this works. When you look at traditional Medicare, kind of in the past, what would happen if you had a kind of a new drug or a new treatment, you would actually hear about companies saying, hey, we're trying to get Medicare approval for this. So just because you have Medicare doesn't mean a doctor can order whatever they want. They still have to kind of meet medical necessity. There's some requirements that they have to meet to provide that care. But once you meet medical necessity, you don't have to jump through a bunch of additional hoops like you do with Medicare Advantage. I'll hit the next slide. So why is healthcare so expensive? Robert and I, we run little hospitals in kind of the middle of nowhere, Nebraska. We're part of the U.S. healthcare system. We really can't change that. We can try to provide a great community hospital in the environment that we're in. But we have a set of rules that we have to follow. That's if you want to change the U.S. healthcare system, you're gonna have to go run for president. But I think there's clearly some industries that are really taking advantage of it. And this is just a slide that actually the Nebraska Hospital Association shared, and you can kind of see the profits of the large insurers out there. And so, and when you think about it, these are organizations that don't really provide a good service. They shuffle paper. And you can kind of see where a lot of that profit has gone. If you want to hit the next slide. A couple of things. So in 2022, more than half of the hospitals in the U.S. lost money. That year, I think 60% of the hospitals in Nebraska lost money. Record profits were generated, and I think this top right, graph is kind of important. You look at that little green slice, and so this is lobbying donations to politicians. And you look at the dark blue, that's life sciences, so that would be your pharmaceutical and medical device. You look at the lighter blue, that's your insurance industry, and then that green is what would be considered providers. So that'd be your hospital association, it would be your medical associations. And so you can kind of see there's kind of some influence directed that way. So you can kind of see where the influence is and where the money kind of goes. I'll hit the next slide. So for us, hope some of you have been to North Platte to have treatment. We're a local nonprofit community hospital. We're not part of a large system. So our mission, since I got the healing that patients first always, we've come to the conclusion, and our board has, that with Medicare Advantage, we can't put the patient first always. So if you want to put the next slide. And we'll kind of walk through that our belief and our board's belief is that it's bad for patients, limits choices and delays care, and it's actually bad for taxpayers. One of the reasons that the government moved to Medicare Advantage is that the private industry can do it better and will actually save the taxpayer money. It's actually been the exact opposite when you walk through this. So hit the next slide. So as I'm sharing with you, don't take my word for it. There's a couple of resources I think you should go to, and make sure they're independent sources. Probably the most important one. So the U.S. government, there's the Office of Inspector General, the OIG. You've heard that term multiple times. They had a large study on Medicare Advantage plans, a complete report. You can jump online and read it all. And it's hundreds of pages, so it's not that exciting, but I have a couple of highlights from it. If you want to hit the next slide. And so basically it's saying that there are a couple of issues that they're seeing with Medicare Advantage. They are supposed to follow traditional Medicare guidelines. So they are allowed to have their own independent internal criteria, and they're allowed to do the prior authorization process, but they're supposed to follow traditional Medicare guidelines. If medical necessity is met, they're supposed to provide that care. So what's happening is that, as they go through prior authorization requests, 13% that were denied met Medicare coverage criteria. And, this is basically from their report. It kind of walks through all of the different issues that are out there. And then, of course, they kind of go back to, I'm talking with your wonderful utilization review social work team, and they'll talk about how there's not enough documentation to approve the request. As they walked through that, and as the OIG did the report, they said enough documentation was there. It's just kind of this tactic that they utilize to delay and deny care. We, in the state, we have a hospital association. We kind of get to know leaders of different hospitals, and there's definitely ones that you kind of connect with and kind of mesh with, and Robert's one that I have a lot of admiration for. We both have a clinical background. Many of you know him as a therapist. He's treated a lot of you. My undergraduate was in nuclear medicine, so I did like cancer staging. I did like the scans for that. We treated thyroid cancer, did nuclear stress tests, those types of things. And so we're two people that we, as healthcare administrators, we actually want less healthcare administrators. We don't want these jobs where we have all these people, shuffling paper, fighting with insurance companies, and spending a bunch of time just doing things that are pointless. We want resources to be utilized for care. And so you can see that what's happened with this is it's increased the administrative burden pretty drastically. So I'll hit the next slide. And then payment denials, it kind of walks through. 18% of the denials met Medicare coverage rules. And then, of course, if you fight long enough, eventually you can get these overturned, but kind of the goal of this is to deny it right away. And again, Medicare Advantage companies get a lump sum, so that's what they're incentivized to do. If you hit the next slide. There's a division of the Boston Globe called STAT, and that's kind of this healthcare reporting arm that they have. And these are some of the issues that have come up probing Medicare Advantage plans on how algorithms factor into care denials. When they looked at one of the largest Medicare Advantage insurer, they spent less than a second reviewing claims. They just kind of had an auto process where they denied the claims. I'll hit the next slide. So this is some data from Great Plains Health in North Platte. And the way that Medicare works, it's a little bit different for a hospital like North Platte. It's a PPS hospital, Prospective Payment System hospital. Cozad's a critical access hospital, and so there's a couple of differences. So we kind of the larger hospitals, we actually lose money on Medicare. This is kind of how the system works. So we get paid about 80% of our costs. Medicaid is about 60% of our costs. And then, we provide a lot of charity care for people that don't have means. And then what happens is to make up that difference, people with insurance, so those of you that are insured or when you were insured, that's why you were overcharged. You're charged this high amount of care to kind of make up that difference. It's called a cost shift. Now, the way that Medicare works is if someone comes in, if you come in for pneumonia, and they'll say, okay, the average patient with pneumonia costs $10,000 to treat them, so we get paid about $8,000 for it. And whether you stay 3 days or 30 days, that payment is the same. And so, there's kind of one of the bigger issues we're talking with your nursing home is that, so you'll come into the hospital, we'll take care of your acute issue, and then we're supposed to get you on to the next level of care, take you to a skilled nursing facility, get you to a rehabilitation hospital, or discharge you to home. We have to provide a safe discharge. If you're not safe to go home, we have to make sure we get you to another level of care. And so what will happen is that we have to go through this prior authorization process to get you into a nursing home. That takes a couple of days, and it becomes very burdensome for the nursing home as well, that we can talk about later. But so for us, the length of stay was about 2 days longer for a Medicare Advantage patient. And that might not sound like a big deal, but if your average length of stay is 4 days, you go from 4 days to 5 days, your costs just increase about 25%. And a really good hospital has a 3% profit margin. So, you can't increase your cost 25% if you have a 3% margin. So those are some of the issues there. But the bigger issue for us, and you've seen this, at your critical access hospital and other places, is that there's not enough nurses out there. We could hire quite a few if they walked in our door today. And so what happens then is that we have about a dozen patients every day that don't need to still be in our hospital. They could be somewhere else. And so then what happens is, Cozad or Grant will call us up and say, hey, we got a patient we need to transfer to you. And if we don't have the nurses to staff those beds, they have to go somewhere else. And, the next closest hospital for us that, you guys are kind of in between us, which is probably kind of nice. You have some options, but the next closest hospital is 100 miles away. And so if you have someone in Grant or Ogallala, for example, if they can't come to North Platte, they're now driving 150 miles. Their family has to go 150 miles to visit them. So it's really restricting the care and our ability to care for patients and for our community. The next slide. Again, this is back to this division of Boston Globe called STAT, and they put out that UnitedHealth, they use secret rules to restrict rehab care for seriously ill Medicare Advantage patients. And it kind of walked through that they put together an algorithm that had no basis in clinical evidence. So they were providing their own standards of care. Through this, they actually filed they used a third-party company called Navi Health to deny this care. And there's a big class action lawsuit right now that's been put in place against United and Humana for illegally denying care. I'm going to hit the next slide. And so you can see that they strayed beyond Medicare's detailed set of rules. I think this is interesting, kind of this last paragraph. Older people who spent their lives paying into Medicare are now facing amputation, fast-spreading cancers, and other devastating diagnoses. They're left to either pay for their care with themselves or to get by without it. If they disagree, they can file an appeal and spend months trying to recover their costs, even if they don't recover from their illnesses. And so it's really, I don't know about, but you see someone kind of hit this vulnerable stage of their life, which is why you have Medicare. It's a safety net to care for you. And you see kind of this behavior is just not acceptable. The next slide. And this was United Healthcare's response. And so, of course, they'll probably drag out this lawsuit for about 5 years, is that they failed to act and go through all of the appeals process. So they think the case should be dismissed. Then, of course, the attorneys that filed this class action lawsuit, they said these are elderly people. They suffered medical traumas. If they opt to forego care while waiting for a decision on appeal, they risk further serious injury or death. And so that's kind of the process that's happened. That this is the class action lawsuit. This is what they're saying back and forth, even though they clearly aren't following Medicare guidelines. They're trying to dismiss the cases because we're hitting people at a vulnerable time of their life, or maybe that last 1 to 3 year of their life where you're going to need medical care during that time, unless you're immortal. But I haven't met anyone that's that way yet. All right, hit your next slide. This really doesn't apply here, but there is when you're in a hospital, there's what's called inpatient status, and there's what's called observation status, and it's a Medicare term. Makes no difference to you. You guys are in a hospital bed, and really frustrating for physicians because we'll say, are they inpatient or observation status? And they'll say, I don't know, just put them in bed. But there's criteria that is followed that will qualify someone for inpatient versus observation. And so your hospital will typically get paid more if they meet the criteria for inpatient status versus observation. And what happens with the Medicare Advantage plans, they're able to push about 18.5% more to observation, even though that person meets inpatient status. So not a big deal, but it does have issues if you need any post-acute care. If you're an observation patient, that post-acute care is not covered. If you're an inpatient, that post-acute care is covered up to a certain amount. So there's just some issues with it. Hit the next slide. So this is from the New York Times. These are your top 10 Medicare Advantage plans, and when you see them listed there, the first column is this company's been accused of fraud by a whistleblower, so someone that worked for him. Second column, accused of fraud by the U.S. government, and the third column is overbilled the government according to the OIG, and you can kind of see how the companies have behaved. Next one. So this is a small hospital in the South, and you can kind of see that Medicare Advantage is threatening rural hospitals. It's a really big issue for communities like Cozad. If you have what's called a critical access status, and I'll just oversimplify this, there's a lot of logistics to it, but you qualify for what's called cost-based reimbursement. And so what will happen is if you have, let's say it costs $10 million to run your hospital, if half your patients are Medicare patients, the government will give you $5 million. And whether that's more than they would, and typically it's quite a bit more than you would give kind of a larger hospital, so they kind of subsidize, because it's critical to have the healthcare in this town. They say that it's that important that we're going to subsidize the hospital being open and being here. Some of the advantages to that in having run a critical access hospital is that for the care that they do here, you probably get the best care here. And because of the way that you're reimbursed, you're able to get a lot of care here. You have good staffing, and typically when you go to a bigger hospital, if you're going to Omaha or something like that, you might have a nurse and a floor caring for 6 to 8 patients. Where here, what's your average nurse to patient ratio here? Do you know offhand?
Yeah, I mean, we say it's going to be 4 to 1, but most of the time it's 2 to 1.
2 to 1. So for the care that you do here, you actually get probably the best care here. Now, obviously you guys don't have oncologists 24/7, you don't have cardiologists 24/7, you don't have orthopedic surgeons 24/7, so there's care that you can't provide here. But just kind of hitting on this, if you have a Medicare Advantage patient come in, and remember if you got Medicare, half your patients are Medicare, you get paid that $5 million and it's $10 million to go to the hospital. A Medicare Advantage patient doesn't count towards that Medicare cost report, and so it chips away at that. And you're seeing pretty severe losses with a lot of your critical access hospitals. Again, it was 60% of the rural hospitals in Nebraska lost money. Now, a lot of these communities, they'll have like a levy, they'll have a tax subsidy that will kind of keep them up. And when you think about your community, you probably have a bunch of neighbors that work at the hospital. It is a huge benefit to your community, but the growth of this actually threatens the status of critical access hospitals and whether they'll be able to survive or not. Next slide. So this is kind of the one that kind of ticks you off the most. There's a group called the Medicare Payment Advisory Commission, and so back in the Balanced Budget Act, they put an independent group together that advises Congress on how to spend money, how to spend Medicare and Medicaid dollars. And so it's a Medicare Payment Advisory Commission, sometimes called MedPAC, and they do a report every year. This is one in 2021. So this is Medicare Advantage payments and their percentage above fee-for-service spending. So you actually had a year where they spent 17% more to Medicare Advantage beneficiaries, to the insurance company. And so kind of the report, Medicare Advantage plan payments remained above what Medicare would have paid for similar beneficiaries in fee-for-service. So FFS is traditional Medicare, fee-for-service Medicare. And of course, they said we're going to increase quality and all this good stuff, and the current quality program is not achieving its intended purposes. And so the last report, so the government spent about $82 billion more giving that money to the insurance companies more than if all of those people would have just been under traditional Medicare. So coverage is worse, patients are doing worse, your health providers are doing worse, and the one's doing better is your insurers. And so you're really just, it's really unfortunate because we talk about the Medicare Trust Fund, it's really accelerating that demise. So as a taxpayer, this should really kind of tick you off. Next slide. This was in the Wall Street Journal. Insurers pocketed $50 billion for Medicare for diseases that no doctor treated. One of the things that they've done is they've kind of pushed, and we've got providers here that really pushed you documenting quite a bit more. And the reason why they've done that is the more that you document, they do a risk adjustment, and the insurers would get paid more if you documented more. And so that was kind of something that they've been pushing with these Medicare Advantage plans. And actually, it's been kind of exposed that there have been some that have been paid for a lot of stuff that people haven't had, that they documented. So I'll hit the next slide. This was just updated, but there's last year and this year, the Nebraska Hospital Association did a report on Medicare Advantage and just kind of walked through just some of the issues that are there, that they report that it's become much more costly to comply with Medicare Advantage. The administrative burden is just really high. Sometimes in the healthcare field, you'll hear a term called moral injury, and and I think that is when if you have a patient that has come to your hospital, probably the straw that broke the camel's back for us. We had a patient that was on Medicare Advantage, very healthy before, got very sick, was intubated at our hospital for a while, and they met all the traditional Medicare guidelines to go to Madonna, a rehabilitation hospital. They really needed that. They were intubated for some time. We provide really good rehab care, but we're not like Madonna. That's the only, we got 2 rehab hospitals in the state. You got Madonna and Select Specialty. So we went through the process to say, okay, we need to get this patient to Madonna. Madonna had a bed, they accepted them. But then we had to get prior authorization, kept getting denied. We ended up appealing it and doing what's called a peer-to-peer, where the physician has to get on the phone with another physician. And we ended up doing 4 peer-to-peer appeals. One of them, of course, they'll only do them from 8 to 5. One of them, they left our physician on hold for a half an hour. So, and then he had a full clinic day that day. So sometimes when your doctor's behind, don't assume they just don't care about you. But they were trying to, appeal this for their patients, and ended up getting denied. This patient stayed an extra 6 weeks in our hospital. We could have seen, with our average length of stay, we could have seen 10 additional acute care patients during that time. We were at a time where we didn't have enough nurses, so there were people calling and saying, hey, we need to transfer someone to your hospital, and we were turning people away during that time. And then, the access issue is the biggest issue, but the financial issue is we got paid nothing for those additional 6 weeks. And it's not cheap to staff a nurse 24/7 for those beds. But anyway, that's what's out there with the Nebraska Hospital Association. They did update this report and send it out. So I'll hit the next slide. Go ahead. So why is it growing so fast? And this is one of the more frustrating things. You guys see the commercials that are out there. Think about it for a second. They're not doing this as a public service. Joe Namath isn't doing this for free. They're really trying to get you on a Medicare Advantage plan, and what they do is they actually pay the brokers. They make up 5 times as much to sign someone up for a Medicare Advantage plan as they do to set someone up on traditional Medicare. And I don't think there's, you know, I don't know that, I think a lot of the brokers don't realize kind of the, you know, their understanding is that this is a good reputable insurance company, and they're supposed to follow traditional Medicare guidelines. This might be better for the person in front of me. So I don't know that there's ill intent in doing this, but they're doing what they're incentivized to do. And then they offer some lower premiums and give you a gym membership, vision coverage, some of those things. But you know, as you look at this, and so it's kind of appealing. You know, don't take a gym membership in exchange for when you need skilled care or rehab care. It's not a very good deal. Next slide. So this is from the Kaiser Family Foundation. This is the insurance gross margin. And so when you pay your insurance premium, how much does the insurance company actually make? And the dark blue is your Medicare Advantage. So this is kind of your individual market, your group plan, and then Medicaid. You know, a lot of these insurers do Medicaid managed care. So Medicare Advantage is their most profitable service line. So that's why there are a lot of commercials. They're really trying to get you to sign up for it because it's their most beneficial service line. All right, next slide. These are some of the headlines. Hospitals are dropping Medicare Advantage plans left and right. We'll kind of go through some of them that have been doing it. Medicare Advantage keeps growing. Tiny rural hospitals say that's a huge problem. Next slide. If you've ever been to San Diego, Scripps Healthcare, they're kind of the premier healthcare system in San Diego. And they sent out and say, we're not taking Medicare Advantage. And when they walked through it, they basically said that we are happy to take original Medicare. Right, the next slide. And then this is the Mayo Clinic. And I think that alone, you know, we probably get 2 or 3 patients in North Platte that maybe get diagnosed with something that's pretty rare. That can only be treated at, you know, some of these really highly specialized places. And we do have, you know, a patient or two that goes to the Mayo Clinic every year. So just so you know, Mayo Clinic, they're not taking Medicare Advantage. But again, that last one, we do accept original Medicare. And so do that. St. Charles Health System, Bend, Oregon, you know, we could go on and on, all of those that are not participating anymore. The next slide. Anthem, lawsuits for $100 million for Medicare Advantage fraud. They're settling whistleblowers. So you can kind of see the lawsuits that are kind of piling up. That little thing off the right talks about Medicare Advantage beneficiaries in their last year disenrolled in Medicare Advantage at a very high rate, realized they couldn't get the care and treatment they need to. One of the things that's kind of frustrating, if you go into Medicare Advantage, they make it really, you can't switch back. They try to make it as difficult as they can. But when you go to a nursing home, my understanding is that when you move there, you can actually switch back. Is that correct? So once the insurance company actually has to start paying claims, then they basically make it really easy to switch back to traditional Medicare. So taxpayer stays on that for it. So at the next slide. Nearly half of the health systems are considering dropping Medicare Advantage plans. And then dozens of health systems asked CMS to crack down on Medicare Advantage plan denials. The next slide. So we kind of had this, you know, we're in North Platte, we made the decision in 2025, we're going out of the network, we're not going to accept Medicare Advantage anymore. Now, obviously, we treat everyone through the Medicare Advantage, no insurance, no pay, we treat everyone. And so we kind of had this, okay, well, we'll just go to Carney then. Catholic Health Initiatives, their parent company is called Common Spirit Health, they're headquartered in Chicago. This is their CFO. They put out a press release, they're having real issues with Medicare Advantage. They ended up canceling a couple of Medicare Advantage plans. So if you have Aetna, they won't accept it anymore. Bryan Health, again, a system that locally owned and operated. I'm pretty good friends with Russ Grunwald, the CEO. He's on the American Hospital Association board. He says their number one issue is Medicare Advantage and the behavior right now. And you know, so it's unless things change drastically, it's a matter of time before these other health systems drop their plan. I'll hit the next slide. This is Troy Bruntz. He's the CEO of Community Hospital McCook. So when you look at our region, McCook, Valentine, Grant, Kimball, Oshkosh, Sydney, Alliance they don't contract Medicare Advantage. When you hear people say that, you know, there's only a hospital doing it here or there, it's, you know, it's even pretty, about 30% of the hospitals in Nebraska don't contract with Medicare Advantage. He had this, you know, he has a newsletter he does every quarter. And I just thought his quote was pretty funny, so I'd like to share it. But ask yourself why these ads run with former celebrities day and night, for months on end, similar to an ad for a Nice or OxyClean. I mean, think about that for a second. Again, it's kind of scammy. So anyway, I just like that's he had a lot of people in his community asking him why don't you accept Medicare Advantage. It's kind of some of the publications he put out there. If you want to hit the next slide. Impact on physicians, and we talk kind of about the moral injury that you'll hear from the people that work at your hospital. There's a lot of frustrating issues and things that hoops they have to jump through, and they're just work that does not benefit the patient, doesn't benefit care. I'll hit the next slide. So again, Great Plains Health and our Health Innovation Network, we have employed independent physicians, and they work together on what's called a clinically integrated network. It's a legal term that kind of allows them to work on quality, what's called value-based reimbursement. It was actually our physicians that said, we think we need to be done with this. We think we need to follow what Mayo Clinic and all these other systems are doing. It's just not good, and we're very frustrated for our patients. And so we won't be basically the first part of 2025. And so I've done a bunch of these forums. We announced this back in about April, and just getting everyone, we want to give people a lot of time to meet with an independent broker and try to make plans to move back to traditional Medicare. So that's what we're doing. And what I say is that Medicare Advantage really is a choice. We want to care for you. We really do. And I know your hospital does. We don't want people going somewhere else. But from our understanding of what we've seen, we think we're better able to care for our patients by taking this position now. I would rather have this conversation with people on the front end. That family that couldn't get to the rehabilitation hospital, I went up there, really administrator called to meet with her son, and he was visibly angry and said that they told me it was just like Medicare, and I'd much rather have this conversation than that conversation. Going to the next slide. Just a couple of things that are out there. This was kind of funny if you've heard about CVS before. A lot of times we think pharmacy. CVS owns a company called Aetna. They're one of the larger Medicare Advantage beneficiaries. And this was a recorded call where he said the goal for next year is margin over membership. So that was the CFO of Aetna saying that. And just kind of the bad there that Medicare Advantage. When I've done a lot of these forums, and some people have been kind of, they're like, well, I have Medicare Advantage. I kind of like what I have right now. It's okay. Well, tell me how you use it. Well, maybe go to the doctor 2-3 times, and that's about it. It works pretty well. I said, okay, well, and that typically does work for someone who, again, only uses it sparingly. But again, unless you're immortal, that last 1 to 3 years of your life, you're going to need it. And so people actually using care is bad for the insured profits. And so that's what's happening right now. Next slide. And that's it. I'll turn it over to you. We need questions after, unless anyone has a pressing one right now. But
Or what do you project then after January 1 profitability in your system for the next 6 months, year, and so forth? What financial impact will it have?
It's hard to say. We don't really know yet. We talked to there's a hospital our size in Brookings, South Dakota that did this. And we talked to Stillwater, Oklahoma, which is where Oklahoma State is. Those Cowboys. They did the same thing, and we talked to them a little bit, and they said that right now there's such a shortage of clinicians. They said we're still busier than we've ever been, and it really hadn't impacted them that much. Hopefully we'll be able to take care of patients better versus spending a bunch of time making phone calls and faxing stuff and fighting with insurers. That's our hope. Okay.
Jump right into it. Okay, I was just going to say something real quick. Ivan touched on the hospitals and the rising cost of healthcare and the problems that we're seeing with all of that on the hospital side. But we want to kind of talk to you about what Medicare how it's going to benefit you versus the Advantage, or how the Advantage would benefit you versus the Medicare. So we want to talk more on how the benefits look on that side of Medicare. So. Have to see what they do first.
Medicare Advantage differs from Medicare in that it is primarily treated as a traditional insurance company, like the Blue Cross, United Healthcare, where Medicare truly is a federally funded program through the government.
It's supposed to be just like a traditional Medicare plan. However, we're finding that that doesn't really seem to be the case. Even though they're supposed to follow the same rules and regulations, we find additional barriers to care that are put in place, and patients are finding surprises that they didn't expect.
They may offer lower out-of-pocket costs for premiums. Much of the time, the cost sharing is different. The pre-authorization requirements are much more stringent and they're higher. They will deny care that would be approved under traditional Medicare guidelines.
The financial side of it may look beneficial, but the services that are covered or opt or allowed are much different. And they're usually taken aback or caught off guard from that because they do not have an understanding of what the significant differences are. And so then when they have an ER visit and they get admitted to the hospital and they realize this isn't covered, and now I have to pay for all of it, or I'm only covered as an outpatient or an observation versus an inpatient stay, it can be somewhat a defining moment for them because they don't have the resources at home to take care of them, and they don't qualify to be in the hospital or a nursing home. And so then their family's like, what do we do with this? And it causes some pretty significant distress.
Another struggle we see with Medicare Advantage is delays in necessary care. So it's very frustrating for our physicians and their patients when they order a test or procedure and they have to wait up to 15 days to receive determination on whether or not they can have that service, whether it's an MRI, a CT scan, approvals for physical therapy. It's all a big challenge to try to get the care they need in a timely manner.
Medicare Advantage truly is having a huge impact in our community and hospital, merely because of the campaigns that they show. They're really pushing Medicare patients to sign up for Medicare Advantage, saying it's lower cost. The benefits are just the same as Medicare. The impact to the hospital is truly providing a financial burden for us.
More and more over time, I think we're going to see, certainly it's occurring nationally, and now it's starting to be seen regionally, is that many providers and facilities are no longer accepting Medicare Advantage plans. People in our community that do have a Medicare Advantage plan are going to have limited choices in terms of specialty services and providers that they can see in the future.
My advice would be to research both options, make sure you understand them, and research from independent sources. The United States Office of Inspector General has a detailed report on Medicare Advantage and some of the issues with it. But my personal advice would be seek traditional Medicare. You'll be able to be seen wherever you want to be seen with traditional Medicare.
I love rural healthcare because the impact you're going to make on people's lives is far larger than any tertiary facility will ever be. And the same doctors that you see in the clinic, in the emergency room, in the hospital, are the same ones that are at baseball games and football games and the grocery store and church. The accountability to make an impact is so incredible, and the opportunity to change lives is much higher.
Healthcare is one of the key cogs in a rural local economy. It's very important to support agriculture, small businesses, and helps to recruit and retain people of all ages in our community.
I think that the lives in rural America is just as important as the lives in urban America. And we need to make sure that they have good access to high quality healthcare.
I'm Lori Masnick, and I believe that strong rural health makes a strong rural Nebraska.
All right, so we have just kind of Medicare basics information.
These are your handouts that we provided. We're just gonna kind of go over those.
So Medicare, you're eligible for Medicare when you turn 65, or if you've been on a qualifying disability for 2 or more years, then you're eligible for Medicare. Obviously, we're putting this out there right now because open enrollment is coming up October 15th through December 7th. Let's see. Medicare is a federal health insurance plan for those who qualify versus Medicaid, which is a federal health insurance, which is given based on your qualifying income assets. Where you can receive help with Medicare using public resources like the Nebraska Area Agency on Aging. And our contact information is on there too, so we're happy to help
navigating through these difficult times and trying to figure out what's best for you guys.
So the parts of Medicare, so there's A, B, C, and D. So Part A is your hospital stay, so that would be if you were considered an inpatient at our hospital. And that's also what you would use if you went to like a skilled nursing facility. So if you needed to go somewhere for additional rehab, you would use your Part A benefits there. And then you would also use your hospice benefits under that Part A. For your Part B, that's like your doctor's visits, your specialty clinic visits, your home health care. If you needed any durable medical equipment, that would also fall under the Part B. Now the Part C is your Medicare Advantage plan. The Part C, or the Part A and B are combined together to make the Part C, which is the Advantage plan. There are some extra benefits and exceptions with that as well. And then your Part D is your prescription drug coverage. So if you have traditional Medicare, you will not have that Part C plan. Your A and your B would be together, and then you would have a Part D for prescription. Now, if you had Medicare Advantage, again, those would all be combined together, and you would have one card for your Medicare. Just kind of want to break down the difference between traditional Medicare and Medicare Advantage. So access to doctors. Most doctors in the US accept traditional Medicare. On the other hand, Medicare Advantage, there are physicians and facilities that are no longer going to take Medicare Advantage and be out of network.
That's something to focus on for those of you guys that are snowbirds or go out of, different states to go see family and stay out of state for a while. This will affect you if you have the Advantage plan.
Specialists, if under the traditional Medicare, they do not require a referral. If you were to see a specialist with your Medicare Advantage plan, they're more than likely going to want a referral, and then also maybe the prior approval in order to see that specialist.
And then that would delay your treatment. Could be 3 to 5 days, could be 7 to 14 days. So it would delay your care.
And then when traveling, again, kind of the snowbirds, you live here in Arizona, your traditional Medicare would cover that. Your Medicare Advantage is only going to be what's in network, and it's usually like a geographic, a regional area for those Advantage plans. Hospital stay limits. There is no limit. There is a limit, but there's not. But we and you get to decide that along with your providers, your medical team, how long you kind of need to be in the hospital with traditional Medicare. For Medicare Advantage, again, you would come into our hospital. We would contact your Advantage plan, say that you have a UTI. With that, they would determine then how long you get to stay in the hospital. Even if your provider says that they want you to be on IV antibiotics for 5 days, they could only approve you to be in the hospital for 3 days. And then it's up to you and the doctor, kind of what the plan is after that. As far as labs, x-rays, and diagnostic services, generally those are covered under the traditional Medicare and do not require an authorization. With the Medicare Advantage plans, I know it says 3 days on there, but it could take up to 15 business days, which is again a delay in care, especially if your doctor wants to see you, in 2 weeks after you get that x-ray. Say they schedule you in 2 weeks and they said, oh yeah, get that CT scan and I'll see you in 2 weeks. It could not be approved in that 2 week time, and you show up to your doctor's appointment and, well, I haven't done the CT yet. It hasn't been approved yet. It's still in that process. As far as home health and medical equipment, the home health and medical equipment is covered under that Part A. No authorization is required. For Medicare Advantage, again, we have to send in that information to your Advantage plan, and they get to determine if you get to be on home health or not and how long you get to stay on home health. Same with like the durable medical equipment, if you qualify to get a walker, wheelchair.
The thing I'd say on the home health side of things is there's a delay there. So you go home from the hospital on a Monday, the doctor wants home health to come in and see you Tuesday or Wednesday, you got a wound care that needs to be checked out. And the Advantage plan has to go through an authorization process through the home health agency. And so your follow-up after you've been discharged to home could be delayed and could cause some problems with how your care is going and
Which could then lead to another, rehospitalization. And then physical therapy, occupational therapy, and speech. Again, they're covered under traditional Medicare as long as they're medically necessary. And then for Medicare Advantage, that's also an authorization process. We'll touch on that. I have another slide to go into more detail on that.
That's just our information for you guys to contact us after this presentation. So, and the Nebraska SHIP, we're really actually hoping to have a SHIP representative here to give some more information as far as timelines and stuff to go when you transition from Medicare Advantage back to Medicare, if that's what you would choose, if you've already been on an Advantage plan, or maybe you're on traditional Medicare and you want to go to Advantage. They're a good person, good contact because they kind of know the timelines. As far as like if you've been on it for a year, you can go back to traditional Medicare with no penalties and pick up your supplement again. But if you've been on Medicare Advantage for over a year and you want to go back to traditional Medicare, you can go back to traditional Medicare with no problem. You just wouldn't be eligible for your supplement anymore. So then you'll have to weigh out those costs. Whether you're going to have more costs from Advantage being in your care being denied and having those costs, or have the 20% that Medicare doesn't pick up because you don't have that supplemental insurance anymore.
Yeah, they will let you, you can get a supplement, but they'll make you go through medical underwriting.
Yes.
So it's possible,
Yeah.
depending on your health, but they could deny it if you have maybe.
If you've got chronic health.
One of the things that we've been in touch with the politicians is that the law states that there's a big change in provider that you qualify for what's called a special enrollment period. And so that would open up access to a supplement without having to go through medical underwriting. We're trying to get an answer to that. Our understanding is that that will actually open up in this region, but we don't have any confirmation of it.
So I just kind of wanted to explain physical therapy, occupational, and speech therapy. Traditional Medicare versus Medicare Advantage. So I'm just going to use a relative of mine had a stroke. So if a relative of mine had a stroke and they needed to see outpatient physical therapy and occupational therapy and speech therapy, as a traditional Medicare, no authorization is required. So PT and ST are combined to meet that $2,330 in a calendar year. And then OT has its separate $2,330. So once you have met those, as long as the provider deems it medically necessary, you are able to continue with physical therapy, occupational therapy, speech therapy. Now, as far as the Medicare Advantage, relative had a stroke, we would have to get an authorization for you to come in to complete those 3 therapy sessions. Once we have the authorization, they could give us maybe 5 days for PT, OT, and ST. After those 5 visits, which you have to pay a copay for each of those therapy sessions. So you're paying $90 a day for each of those 5 visits. After those 5 visits, we have to get more days approved for you, which is then going to require a peer-to-peer conversation. So our therapist calling your Advantage plan, speaking to a therapist and begging for more therapy days, sending in additional information, saying you need more days. They might come back a week later and say, yeah, we'll give you 3 more days. So you get 3 more days for physical therapy, occupational therapy, speech therapy. Again, you're paying your deductible for each of those visits again. And then after that, they could say, nope, we're done. And then, I mean, if you're not medically ready to not have therapy anymore, that's a huge concern, that your insurance is not allowing you to continue therapy. Another example is swing bed, which is like a transitional skilled care. So Ivan kind of touched on this with their scenario. They were trying to get somebody to Madonna. We're having the same situations here. So again, a relative had a stroke. They're at Great Plains Hospital. They want to be, closer to family. They live here. They doctor here in Cozad. So we're going to submit the authorization for Medicare Advantage. We're going to submit that authorization. That can take 48 to 72 hours on my side. I have to submit that authorization. If I get a denial, then I'm having the provider from Great Plains call the insurance company and saying, yes, they need to go to Cozad for swing bed to continue with therapy. So say that we get that approval. They come to us, they're going to dictate how long they get to stay in our hospital for the continued therapy. Usually they give us 5 to 7 days at a time. And then after those 5 to 7 days, I'm sending in information to your insurance company, hoping that they will give us additional days to continue to care for you. Again, that's usually a waiting period, 24, 48 hours. Sometimes you don't hear back for, a couple weeks. And then it's, kind of just the waiting game. But then at any point they can say, nope, we give you 48 hours and then we're not going to pay for your care anymore on swing bed. For traditional Medicare, no authorization is required. Again, if a relative came in with a stroke, that is a qualifying diagnosis. So our physical therapy, occupational therapy, speech, as long as the provider deems it medically necessary, you're going to come to us and we're going to do rehab. With that, as long as you continue to make progress, we're going to continue to keep you at our hospital. If the goal is still home and you're making great progress, we're going to work with you and your family to get you back home. If we have to look at other routes, such as, the nursing home or something, we'll be working with them. But us, the medical team, and you get to kind of determine how long, you stay as a swing bed patient versus the insurance companies.
And like Ivan stated, with them waiting for our authorization 48 or 72 hours, that person that is medically stable enough to come to a skilled unit or a transitional care unit is sitting in their hospital those extra days. And that's where all the frustrations with the hospitals with the rising costs and everything and the staffing to patient ratio. So then we have somebody sitting in our ER bay that needs to be transferred. Ivan doesn't have a bed for them there because they're sitting on other patients that are waiting for authorizations to go out somewhere else that could have a step down hospital to take care of them.
I actually ran into 2 scenarios this last week with the Medicare Advantages. We were trying to get somebody to our hospital after a hip injury. I obtained the authorization, and unfortunately they said that all of the area nursing homes within a 50-mile radius had to decline this person in order for them to approve it at a hospital level. This patient did not necessarily want to go to a nursing home. She wanted to come to our swing bed where, her doctor is, she knows all of our staff. But unfortunately, she was not able to come to us until all of those did decline. They did tell me, which somebody did graciously accept her, but if for some reason no one did accept her, there is a chance that she could have been approved at our hospital, but we had to continue to look for placement if this person was at our hospital, which would have been out of the 50-mile radius. We had to continually show that we were still trying to get her placed at a nursing home level versus just coming to our facility to, get stronger and go back home. I think that's really hard on people if they would have to come to us for 3 days and then have to transition to a nursing home for, 3 days later for then continued care. That's just very hard on patients. Another scenario this week, we tried to get someone to come in, and unfortunately they just said, nope, they don't meet swing bed criteria. They have to go home on home health services.
And then again, home health is probably delayed for them because with Advantage program, they have to wait to get approval or denial.
Obtain that
And if
authorization.
they get denied, the hospital feels like they did a safe discharge plan stating that they're gonna go home with home health, but then later they find out that the home health was denied because there wasn't enough qualifying, whatever they needed, medical need to approve home health. And so then that's not a safe discharge always, and so, like you said, we will see them back in the hospital or the ER again, so.
We just wanted to show like an example of the Medicare cards. Just this last year, I feel like Journal and I, one of us makes contact with every person that is admitted to our hospital. And just a lot of people are like, yeah, I have Medicare, but they don't understand they have a Medicare Advantage. Well, yeah, I have the Medicare card, but they have a Medicare Advantage. So traditional Medicare card versus an Advantage card.
And in order to have an Advantage, you have to be eligible for Medicare. Just because you have the card and someone's called you and said, hey, Joe, I think you need to sign up for Aetna. We have prescription and we have dental. I think it'd be beneficial for you. I see you wear glasses and you need to have probably an eye exam every so often. So I think you should sign up for Aetna. So they get you signed up for Aetna and you still think you have traditional. You don't. You've now signed up for Aetna and you're locked in until that open enrollment or special enrollment period. So to me, it's a little deceiving that you think you have Medicare, but really you've moved on to an Advantage plan. And I'm gonna go out on a limb and just state, Medicare was never broken. They added the prescription D plan to help people that can afford the prescriptions. And when that came about, then I feel like this has just all exploded. And with that, the prescription Part D is a huge benefit because we know that prescriptions are expensive. But with these Advantage programs, with the eyes and the dental and all of that, we've learned, we had a lady that signed up for the Advantage because she wanted to get new glasses and she just didn't want to pick off the bottom shelf. She wanted to pick some fancier glasses. So they told her she'd have up to, $700 benefit or something like that to get glasses, that's a pretty good benefit. But she had to pay out of pocket first. And then they would, Medicare Advantage would reimburse her.
Within 90 days.
Within 90 days, yeah.
So a lot of people, don't have $700 to pay out of pocket for those, and then to wait 90 days to, get that check and hope there's nothing wrong with the claim and it didn't get denied or.
And Medicare, there is a premium. It's $174, $176, $178 somewhere. So there is a premium. I understand that these Advantage don't come with a premium, but when you have chronic health problems, have lots of things, tests, exams, and things you need to have done that's recommended by your physician, those out-of-pocket expenses will add up probably to be more than what your monthly premium would be with Medicare.
We're finding too, just on the hospital side, that unfortunately these Advantage plans aren't wanting to pay for chronic conditions. So they are, giving us a very short time that you can be in the hospital for those chronic conditions. So, Medicare will never call you.
Yes, so Medicare will never call you. You'll get your letter in the mail that says, hey, we see your birthday's coming up, you're turning 65 in December. It's usually about a 3-month window that they send these letters out. So Medicare will never call you on the phone. The phone calls that you're getting are from these guys. These guys are trying to get you to sign up. The insurance agents are signing you up, as Ivan spoke to, the kickback that they get, the reimbursement they get from signing you up to these Advantage programs is huge. It's a lot of money that they're making. So Medicare will never call you. Medicare Advantage will leave you alone.
And they'll say that they're Medicare.
Yes.
They won't say that necessarily that they're an Advantage.
Lou, you had a question?
So the open enrollment part, October to December, that is a Medicare Advantage people? Because I enrolled in Medicare and I never re-enrolled.
You don't have to. Once you're
I know.
Medicare, you stay.
Right.
Yep,
So the open enrollment, if that is for the Advantage plan.
yep, and you want to
Oh.
switch back to the traditional.
I couldn't understand that one.
Or if you were an Advantage plan and wanted to switch back to a traditional
That was at the
Medicare.
same time.
Yes, or if you wanted to switch your Advantage plans, let's say you do like your Advantage plan, you're a healthy person, you don't have chronic health conditions. So then if you have WellCare as a Advantage program, and you want to switch to Aetna, that's part of that open enrollment, you could switch there.
Okay.
Because like, some of the hospitals are just not contracting with one or the other, and some hospitals are getting rid of all Advantage contracts. So those are things you need to be mindful of as well. The other thing I would say is talk to your pharmacist as well. They have to contract with these companies as well, and they're the ones that see it on the prescription side, who would reimburse as well and who doesn't, and what covers your prescriptions best. Because all of us are on different things. We don't all take the same medication, so that's important too. So.
That was my question, was like United Healthcare, Ivan had that showing, it was a slide earlier, but are the different Medicare Advantage companies, are some better than others? I mean,
Yeah.
do you have issues at the hospital with all of them, or some work well?
So as of January 1st, 2024, they're supposed to be following the same rules as traditional Medicare. And unfortunately, most of them aren't, but a few of them are better than others. I still have problems with all of them, but there are some that are follow the rules better, yeah. Does anyone else have any questions?
Yeah, it's a little after 1, so I know some of you probably gotta get back to work and such, and we don't want you to get in trouble with the boss, but any questions, concerns?
So the Medicare Advantage it's cheaper.
Correct.
Yeah.
And you might not have a monthly
Right.
premium.
So I'm making the assumption that people that are gonna go toward Medicare Advantage
Absolutely.
are people that don't have the financial means, and they see the advantage of getting this little premium. Do you have statistics that would show that most people that are on Advantage would be probably lower income?
I think it's kind of across the board, but definitely those lower income, fixed income, social security,
Yeah.
stay-at-home mom, she's only getting $900 because she never paid in. So, yeah, they're gonna gravitate to no premiums a month, absolutely, yep.
I just worry though, if we were to send somebody come, January 1st to Great Plains because they need that higher level of care, but they happen to be out of network, what does that look like for an out of network deductible for them? That is gonna be a lot. I don't know what those look like, but it's gonna be more than the monthly payment of the traditional Medicare.
So it's only good if you're never gonna get sick or never see a doctor, then just
Ever.
one day drop
Yes.
dead.
Yes, yeah.
You can wait 90 days to get your prescription glasses covered. Yeah.
But the other part of that is, I heard Ivan say you're going away from
Yes.
you won't accept it, so then
You're in our, we need to transfer you,
you
and you
can't
have a
go there.
Medicare Advantage.
you're not going to
His
North
team is
Platte.
gonna say we can't accept you because
Okay.
we're not in network with them.
For emergency care, we take anyone regardless of their ability to pay, so like, it shouldn't change your process.
Correct.
Since you know it, and I don't know how you're gonna keep track of all this, and I can't go to CHI now, you know what I mean, like.
Yeah, there's,
We'll take whoever and we'll work with whoever. I think that, some of the comments I've made is that, and I guess I can't speak for your hospital, but I'm guessing that you guys are, very aggressive with your policies and such. I would guess that. So if you have those people that really don't have means, they don't get a supplement, that's fine. Just get your traditional Medicare, and we just try to make a difference if they're truly in that need. That's what we do. And I assume your policy is probably pretty similar, but I think it's worse having that Medicare Advantage plan and not getting the care you need versus having us write off that 20% difference. Personally, that's my thoughts. Sorry to speak.
Well, and I think a lot of times people look, and I'll use you as an example, Chuck, because I see you ride your bike towards Eustis all the time and back. You're pretty healthy overall, so you're thinking, hey, I'm a healthy person, I'm not gonna need Medicare, services much. I'm gonna go with this lower cost Advantage plan, but you don't know where you're gonna be 5 years down the line, you know, and you don't know if you're gonna have cancer or something like that, when all of a sudden you do need to utilize those services, and then boom, you're hit with all these additional costs, you know? Because it's easy on the outside to just say, okay, this person's a healthy person, they're not gonna use the system much, then, you know, an Advantage plan is gonna save them money. But is it really? Because you can't guarantee that I'm not gonna accidentally run you over too when you're riding your bike, you know? I mean, there's just a lot of variables in life as life happens that, you know, are those surprises.
So does Cozad Hospital take Medicare Advantage yet?
We do currently, you know, we've had some discussions about that. We know it's a big struggle. Right now, the number of people that have Advantage plans that use our system is just under 10%. On the eastern part of the state, there's facilities that their Medicare Advantage payer mix is 30%, so they're really getting hurt. I've talked to some people in the southern states, Mississippi, Arkansas, those places. They're already around 50-60%. And really, when you look at the data, as I've mentioned, that you know, a lot of hospitals in the nation, rural hospitals, are struggling. That's a big contributor. You know, in Lincoln or Omaha, you don't have as much of your general population. It's a lot younger, so they're on a regular employee, you know, employer-funded program. You know, here our Medicaid age or Medicare age is quite a bit higher. So, you know, we're just older communities and rural communities. We're an older group, and so it affects those a lot more. But there's a lot of rural hospitals that are being faced with closure. And if it continues to build, there's a projection that shows that by 2030, if Medicare Advantage continues to grow at the rate it is, that traditional Medicare will be phased out, and all you'll be left is these managed, you know, Advantage plans where you're limiting you and your physician, the physician-patient relationship is pretty severely affected with these plans, because when your physician wants to say they're working with you, they've done their clinical exam, they've looked at the diagnostic tests, and they're saying, this is what I think is best for you, then they're being told by somebody else, first line of denial is somebody who's looking at a clinical algorithm, somebody without a medical education, they're being told, no, you don't need that service, you know, and so you get this continued delay, you know. And you cited some of the therapy examples, you know, for anybody who's had a rotator cuff repair or a total knee replacement, you leave that hospital and then we can see that one time and then have to wait maybe 5 or 6 days before we get approval to set up the following visits. And then we get 5 visits and then might have to wait. I know with a lot of the Medicaid plans, I would have somebody who had their knee replaced, and after the first 6 visits, I would have to wait 10 to 14 days to hear back before I could do the other visits. Now, what happens to your knee during that time? It gets stiffer than a dog's leg. I mean, they'll pay for a $35,000 procedure, but then they'll put all these barriers for the rehab afterwards. It doesn't make sense. It takes Medicare Advantage plans take away the decision-making by your physician, you know.
The people that are educated.
And yeah, the people that are educated to do the job. And you know, there's a lot of physicians that are frustrated with medicine because they're being told how to manage their patients, you know, by an insurance company. So.
Would you guys have any idea, just because the Medicare Advantage takes so much more administrative time, would you have an idea of, like you had 2 patients with the exact same thing, one was Medicare and the other was Medicare Advantage, how much time you got staff dedicated to that kind of approval stuff?
I did a full study. The 2 places we talked to, and they did a full analysis, was Working, South Dakota, and Stillwater. They said about, they were losing about 17% of their reimbursement on administrative burden. So, you know, so you take your Medicare rate that's about 83% when all is said and done is what you're getting 83 cents on the dollar versus traditional Medicare because of all that additional. I never did a full study for us, but it seems about that.
Free up staff to do other things or prevent you from having to make additional hires
Exactly.
down the road.
A couple other things, just real quick, for those of you that have a little time. So Medicare Advantage is also sending out you these nice little credit card, debit cards that says, here's $300 of groceries on us. It might work in the urban areas, but our little Sunnies is probably not in contract with it. So now you got a $300 credit card to go buy groceries, but you got to drive to Omaha to go to the grocery store that's contracted with that. Same with the gym memberships.
Golf membership.
Golf
That was
membership.
the one that I heard when I went to a conference. They're paying for golf memberships.
They're also helping you with your energy bill. But I have Black Hills Energy and I'm online, or on the phone, I'm calling to pay my bill, and it says, if you're with WellCare, I apologize, we did not accept that, card for your payment. So if you're, that Advantage program and you've got this extra help to pay your bills, but now Black Hills Energy is not even gonna contract with them to accept payment. So
It's great in the urban areas, but not so
Yeah.
much.
yes,
Yeah. Same with maybe the gym membership and the golf membership.
It's supposed to
But
be illegal.
I was just saying.
It is, yes,
wait,
it
that's
is.
illegal.
well, them even calling you, trying to sell it to you
Yeah.
is not, Medicare never did that. You
I
turned
used to
65, you
sell-
signed
I
up,
used to
you were
sell,
done.
life insurance and crop insurance. And that was one of the first things they did was, now you can't give any side benefits, you can't be taking these people out for wine and dining them to get them to buy your product.
And I know times are tight, and so I'm just gonna put in this one little plug. I'm not an insurance salesman or agent of any sort, but if you go with traditional Medicare and you need a supplement plan, the best plan out there is a Plan G. G is in golf. And you don't have to spend the $200 a month premium. You can get the same coverage with a $46 premium. So just so you know, if your budget's tight, it's kind of like how I explained it to my mom. These pair of jeans, it's a name brand, but these are from Walmart. They cover the same parts of your body. You don't have to spend $200 for these jeans when you can get them for $20. Okay, that was part of my mom's conversation with me when I was 18. Now let's go back to her. So with that, just remember, you don't have to spend a huge premium for a Part G plan. Part G has to cover the exact same thing, whether it's you're paying this amount or this amount. So just be mindful about that.
With Plan G, there is a deposit, or you have a premium to pay at first.
Yes.
You know.
You'll have a monthly premium with your Plan G, yes.
Yeah, I know,
Yeah.
but you have a deductible. You have a deductible.
Your Plan G should pick up what Medicare does not, from what I understand. Again, I'm not an insurance agent, so
Well,
that's maybe
I
where I'll.
save $100 a month on premium, but I have like a $200 deductible pay at the first of the year.
With your Plan G.
But, yeah,
Could be. That very well could be, like I said, I'm not an agent, I just know.
but the saving $100 a month is a benefit.
In the long run, yeah. So, thank you guys all for coming. We weren't sure how many people would attend today, so I'm so glad to see so many of you in the room. Please share this with your family. Those of you, whether you're 55 and approaching Medicare in 10 years, or have parents that have been on, go home and ask them, Mom, Dad, what are you guys on? So you guys just have an idea.
And they'll probably say Medicare, but they could be on Medicare
Yes.
Advantage. Because the amount of people that have come into our hospital these last 9 months, it's crazy that they don't know they have an Advantage plan.
Yeah, and some of them have more than one card like this. They have this wallet. Because the other Advantage will call and say, hey, what do you think of, I hear you need this or that, and they'll sign you up. And then so you don't know which card is even current, because you have to look at the fine print of the 2022 or the 2023 in the corner. So,
And I think they even go as far as to have a dedicated line for their Advantage plans, because they pick up that line and say, thank you for calling Medicare. It's not Medicare, it's
Medicare.
Medicare, or it's WellCare, or it's like
yeah,
you're being deceitful from the get.
it is. And that special enrollment, I'm glad you brought that up, Ivan. I worked with a person here not too long ago that wanted to change. And they said, well, why do you want to change? And so we explained the situation and so we had to go through the process. We got down to 37, number 37, as to what would be a qualifying change for that special enrollment for that person. So they have pages on the special enrollment to get you out of it. And so to me, that also speaks volumes that they know that it's not a great coverage plan, that they have more than 37 bullets as to why you can change a special enrollment period. You know, that's crazy. So-
Well, I want to thank Lori for hosting this here
Yes,
at the
thank you.
library.
Thank you.
Ivan from making the trip down from North Platte, and then he's actually going to be here next Wednesday as well.
Tuesday.
Or Tuesday, okay,
Grand
at the Grand
Generation.
Generation Center.
Yep.
So spread the word if you have anybody that you think might benefit from another session, let them know. If you've got a question, just didn't feel comfortable asking it here today, we've got those magnets, the information, Joel and Miranda's cards, you can call them, so.
And then, next Wednesday, we're gonna do kind of a panelist, out at Paulson's at 6 o'clock. There's gonna be somebody from the local pharmacy, one of our providers, the administrator from Emerald, Nursing Home, a physical therapist, Sandra Nall.
Hopefully someone from Frontier Home Medical. We've reached out to them, we just need to confirm that one, so.
There'll be an actual insurance sales rep to talk
Yes.
about their side of insurance sales. It's very transparent.
So there's lots more questions. We probably won't go much into detail. It's gonna be kind of more, what is pharmacy seeing, the difference in Medicare versus Medicare Advantage.
Yeah.
So if you guys wanna come back to that one, we would love to see you there.
And if you decide you want to change your Medicare Advantage to just traditional Medicare, it's just 1-800-Medicare. Just call them and let them know what you want to do. It's a pretty easy transition, they're easy to work with, so.
Thank you.
Thank you. Yeah, thank you for coming.